And then please, as you have questions, don't hesitate to ask them as I'm speaking. Otherwise, I definitely want to make sure there's enough time for questions in the end. So I'll just get started. As I mentioned, so I work for Aurora Healing and Advocacy Services. We're a department operated out of Aurora Sinai Healthcare downtown in Milwaukee, and a part of Advocate Aurora Healthcare. I'm the manager of our volunteer and advocacy programming, and I'm happy to speak to you today. So a little bit about what we do. So we have a multidisciplinary team consisting of forensic nurses, advocacy, and trauma therapists. So we have a 24/7 forensic nursing program, which I'll talk about more in a second in a little bit more detail. Day shift advocacy for survivors. And then we also offer individual and group counseling, specifically for survivors over 18. And although we provide care medically for domestic and sexual violence victims, our trauma therapy is focused more on sexual assault. We do also have a 24/7 confidential hotline, along with a confidential text line that, although it's not 24/7, it is confidential. So we are the largest program in Wisconsin. There are other hospitals in the Wisconsin area and the Milwaukee area that offer forensic nursing. We're a larger program in that we've been around the longest, but then also we're very unique in our programming. So whereas other forensic nursing programs might work with outside agencies only for advocacy and therapy, we have in-house advocates and therapists as well, although we certainly rely on and work very closely with community partners because we have such a large volume. So we also have a program called Safe Mom, Safe Baby. This program addresses the needs of pregnant and postpartum women. So we have a domestic violence, we have a nurse case manager who works with pregnant women to ensure that they have healthy birth outcomes. As they're experiencing violence, a lot of stress to themselves, their body can be taking place, and the nurse manager works with them to ensure safety and helping them get to their appointments, etc. Through that program, we also have a subsidized housing program called Safe Home Environment, or SHE, where we're able to provide subsidized housing, studio apartments at a very low rent to women who have just given birth, who've experienced domestic violence, as a way to, for them to get back up on their feet. We do have a few different locations. So as I mentioned, we're primarily located out of Aurora Sinai. Prior to COVID, we had a counseling location, but all of our counseling has been virtual. We also operate out of the Sojourner Family Peace Center. We're a co-located partner there. And then we respond to Aurora West Dallas Medical Center as well. So in terms of our medical services, our forensic nurses are specially trained in being able to work and provide support to victims of sexual and domestic violence. So we offer services to all victims. We say regardless of time frame, and I'll talk a little bit about where that does not always ring true in the next slide, but we do provide services to all ages and gender when it comes to the medical services. All of our services are free and covered through available support. And then our services are voluntary. So what's really important when working with survivors of sexual and domestic violence is that we're offering them choices for what, they're driving the bus. We want to make sure that they have they can make informed decisions. We talk through their options. Even when it comes to folks who are under the age of 18, we're never going to do services that they don't want. The only piece that might come into play is mandated reporting. So when it comes to medical services, medical needs come first. Anytime someone comes to the hospital after a sexual or domestic violence incident, they may not be initially or immediately seen by the forensic nurse, because we want to make sure that they have no other injuries. So if they have other injuries from the assault, those need to be addressed first. So that might mean they're getting x-rays or CAT scans or anything like this. But once they're medically cleared, we can see them. So the forensic nurse does what is like a forensic history taking. They're asking a little bit about the assault. They don't need detail after detail, but a lot of time they're asking what kind of contact took place, when the contact took place, etc., because that helps guide their practice. So we can do a head-to-toe physical assessment. We can provide prophylactic treatment for STIs, meaning that we can provide that medication without a result of a positive STI test. We can do photo documentation. We have a really fancy camera that can zoom in on bruises that have not yet broken into the skin. This is a big use for domestic violence victims. So the services that they may need from a forensic nurse are not as high if they don't need an examination, but a lot of domestic violence victims coming in may want that photo documentation for evidence. We can provide emergency contraception. We have an emergency contraception we use that allows us about a 5-day window. Evidence collection is usually can be done within a 5-day window as well. So if, for instance, we had someone who came in on Monday to our department who had been assaulted on the 14th. So, we could test for STIs and do, head-to-toe physical assessment for them. But aside from that, evidence on the body really isn't going to be as present or present at all at that time. And then we can do a toxicology screening. So when it comes to folks who think that they may be assaulted due to drugs, like a drug-facilitated sexual assault, we can do that screening, but the timing really depends. A lot of those drugs are meant to leave the system very quickly, and we only can do that screening if they're for sure going to be reporting to law enforcement and getting evidence collected for that. So folks can get evidence collected whether or not they're sure if they want to report or not. They usually have about a 10-year window, we say. That's the statute of limitations on most sexual assaults. So folks may get that evidence collected but aren't sure if they want to report yet. And then other times folks are very sure that they're reporting. They've maybe come with the police, or they've asked that we call the police for them, and then we'll collect that evidence. So we also have advocacy services. Advocacy services, first of all, that's victims have a legal right to an advocate in the state of Wisconsin. So they can have an advocate with them during the emergency department visit and forensic nurse services. And they can also have an advocate present during any sort of law enforcement involvement. That advocate is primarily responsible for providing emotional support and trauma education. They can help provide information on community resources, help with safety planning. They can really just, it's that providing emotional support, helping reduce trauma reactions, but they can't add to a survivor's story or speak on behalf of them or provide legal advice. So they're not a lawyer. They're a confidential, privileged support person to help them navigate what can be very complicated systems after an assault. Our counseling services are available, again, as I mentioned, for folks 18 years and older. But we can do both short-term and long-term counseling. We do offer therapy. We have groups, but we're not doing those right now with COVID. We do have a Spanish speaking program, so we do work with folks who primarily speak Spanish. And then we have connections with alternative therapies as well. And we offer topic nights to our clients. So meaning that we'll have monthly, bi-monthly nights where they can come together and we're speaking about a specific topic related to survivors. As I mentioned, all of our services are free of charge. If someone is coming to the emergency department and needing services outside of what our forensic nurse does, so if they do need that x-ray, that CAT scan, they need anything else done in the ED, that's something that either hopefully is billed through their insurance and covered that way. But for anyone who is looking for forensic nursing services, if they don't have insurance, if they don't want their insurance billed, there's something called the SAFE Fund, which allows folks, it's so that folks don't have to pay anything from their forensic exam. And then any victim of crime ever is, if they're reporting to police, have the right to apply for crime victim compensation. So those are things that we support our patients through and navigate. And services are provided for those without insurance. So our counseling services, we don't even take insurance. All of that is free. We are a grant funded program within the hospital. Just a little bit about our service numbers. I know it's 2021. 2020, as you can imagine, was a weird year. So I'm still sharing our 2019 numbers because I think they more accurately represent our services generally. So we did work with over 400 survivors on counseling services. We did see about 590 patients for forensic nursing care, and then provided over 1,500 instances of personal and systems advocacy. We helped 83 expectant mothers, 134 victims of domestic violence, and we fielded over 3,000 calls on our 24-hour crisis line. We also did a lot of community presentations, which is also something we do. So then I was going to speak a little bit about more into sexual and domestic violence and some trauma-informed care. I don't know if anyone had any questions about our services yet. Otherwise, again, there'll be time at the end, but I can pause here in case folks have any questions now. Okay. So I know that you guys recently watched a documentary. So, you're probably like, hello, we know what sexual violence is, we know what domestic violence is, but I always like to talk about the definitions because we work with folks who don't know if they were sexually assaulted, and it's nice to be on the sort of the same page with that. So really, we define sexual violence as any actual or attempted act that is sexual in nature where consent is not given. So that can also mean it's non-contact, right? So that's a form of sexual violence is catcalling. It can be folks posting lewd photos that maybe you only had shared with that one person. It's voyeurism. So that non-contact also is included as well. Other terms, obviously, sexual assault, that might be used synonymously with terms like rape or sexual violence. Sexual abuse, we often use to refer to children. So children are sexually abused, maybe an older individual, usually a more vulnerable population, and often sexual abuse is considered too when it's a caregiver. But there are other definitions. So there's legal and statutory definitions, historical definitions, culturally specific definitions, and so on. Sorry, my cat is going to be a little talkative. So sexual violence is unlike any other crime in that it's intensely personal, right? A victim may feel a wide spectrum of emotions: fear, humiliation, loss of control. They may feel as if it wasn't their fault, and it's often not believed. So when folks, it's very, like we live in a society that can be quick to say, oh, that's not true, that didn't happen, they're obviously lying. but statistics show that someone lying about sexual violence is no higher than, I think it's like 3 to 8%, which is no higher than any other crime being lied about. So there's really no evidence of that yet. You often, you never second guess someone being mugged or whatever other crime might take place. So domestic violence, also referred to as intimate partner violence. That's a pattern of behaviors used by one partner to maintain power and control. Power and control are at the root of both sexual and domestic violence. It's one person wanting to take control over another. And multiple forms of abuse are usually present at the same time. So, domestic violence can be extremely complicated, because whereas sexual violence, you might not be in a relationship with the person or have ever been in any kind of relationship with the person who's perpetrated that. Domestic violence, you might be living with that person, you might be sharing children with that person, so the lives might be a bit more intertwined. Again, feeling array of emotions and feelings. Physical and sexual assaults or threats to commit them are the most apparent forms of DV. And it's really important to assess safety and concern while allowing that patient to still make their decisions. So if you've never seen the power and control wheel, that's a very popular sort of symbol and tool used to explain the power and control that goes along with domestic violence. Cycles of violence usually can involve emotional abuse, verbal abuse, isolation might be involved. As you can imagine, there's been a very high concern about domestic violence throughout this past year with COVID. Safer at home orders, folks staying at home more, really allows for more of that isolation. And may make it harder for survivors right now to be able to leave. So there's been a lot of stuff about domestic violence increasing. So yeah, just all of these pieces really are put into play. So domestic violence can be really misunderstood. It's really common for folks to be like, well, why don't they just leave, right? So one thing to know is that leaving is the most dangerous time for a victim of domestic violence. So that meaning that could involve in homicide or murder. Often a victim leaves, I think it's about 7 times before leaving for good. But a lot of folks who are experiencing domestic violence, when asked about it, they just want the violence to stop, right? They'd stay with their partner if the violence was gone. So, there's this desire for a normal family. You want to keep that family unit together. Children might be involved. You might have family who don't or are in a culture where divorce isn't understood. Lack of support, feeling as if I deserve this, etc. And again, that isolation and things can be very real. So you can't talk about those two things without talking about trauma. So both of these things are very traumatic victimizations. And trauma is, trauma is any experience or situation that evokes fear, changes an individual's worldview, or changes their view about them itself. So trauma can be anything that happens that you weren't expecting. A traumatic event can be a car accident, a death in the family, so obviously there's other pieces to it. Trauma, I won't go into the whole neurobiology of it, and I'm sure as folks who are soon to be in the health field, you've had some courses on this, but a lot of our reactions to a traumatic event are very evolutionary, embedded in our brain science and how we react. So you've heard of the fight, flight, freeze, or you might have heard of fight and flight, but fight, flight, freeze, and then there's even appease, are common reactions to a traumatic event, trying to fight back, trying to leave, completely freezing. And then appeasing is, doing whatever you can to just make it stop, right? So all of these things are often something that maybe like in a rational situation you wouldn't have done, but because your emotional brain is taking over in these instances, there's a lot that you can't control in that moment, even in how you might react. So there's a lot of reactions to sexual and domestic violence trauma, emotional, mental, behavioral, and I'll talk about some of those. So we like to say that any person who's experiencing trauma or crisis, any reaction is normal. So, there's no wrong way to act. It's how you're experiencing it and how you're reacting. So that can manifest itself in a lot of different ways, whether it be these physical effects, emotional effects, as you can see too, a lot of all over the board in terms of emotional. We've worked with patients who are laughing and giddy. And a lot of that has to do with just so much energy being in your body still from this event, that it's manifesting itself in this sort of like giddy, and that's just your energy kind of escaping. I've been in a near car accident where I've gotten okay and I'm driving away and I'm like laughing because I'm just so stressed. I can't believe what happened. So lots of different ways that manifests. Mental cognitive effects. So feeling like, am I damaged goods? Am I dirty? I deserved this. Trying to forget about it, right? Like, okay, I'm just going to pretend this never happened, etc. And then a behavioral impact. Any kind of trauma can really affect and change a person's lifestyle. You can have difficulty getting things accomplished, difficulty with intimacy, feeling being fearful to be alone. If you don't have maybe what we'd consider healthy coping skills established or support, you might turn to things that aren't as healthy, drugs, alcohol, all of these things just as a way to cope through what's happened. So that's why trauma-informed care is really important. There's 6 guiding principles to trauma-informed care: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and then culturally competent care. A lot of this is already I talked about. Really important though, to develop trust. When you're working with someone who's experienced trauma, you want to be a trustworthy person. Develop that partnership or sharing power, right? So, in your future, in your field, you're going to be considered, there's a power dynamic that comes into play, right? You're seen as this expert person. But when you're working with someone in trauma and supporting them, you have to remind them that they have that power and control too. When they've had that taken away from them, we want to give that back to them and remind them that they're the expert on themselves. So that comes into play with the creating choice and building empowerment. Be mindful of the position in the room. So are you sitting? Are you standing? Are you looking dominating? Maybe are you not blocking the door, right? Always asking for permission to touch or hug. So folks, those touchy-feely folks, like, oh my God, I just want to give you a hug. I want to stroke your shoulder. Those are things to be mindful of and might not be appropriate for someone who's experienced that mistrust with their body. So always ask for that permission. Maybe if you're getting near someone and, always explaining what you're doing to the body or what they might be feeling. That can be really empowering for someone who's experienced a trauma. I always respect I really appreciate when healthcare providers are explaining, okay, now I'm going to be touching this and this is why, whatever that is, so that there is that expectation. So if you're working with someone and they disclose a sexual or domestic violence, first of all, it's okay to ask those questions. A lot of healthcare Aurora Advocate, Aurora including, does have and those safety screening questions. If you've gone to the doctor recently, you've probably had them too. Are you feeling safe at home? Have you ever been in an abusive situation, etc.? So, ask those questions, believe them, right? That's the most important thing. Offer acknowledgement and support within the context that you can. Make a commitment. Also important too, when we're engaging in this work, we're not without our own traumatic experiences, right? So be mindful of yourself. What are your triggers? What's your trauma history? Do your own work before, because you certainly, if you're triggered by something, you're not going to be able to care for that person either. So that trauma-informed practice is really important. It's about applying compassion. Recognize that, people are always, they're doing their best, right? So trauma, again, as I mentioned, it can manifest itself in a lot of ways. We work with patients who've experienced a lot of complex trauma throughout their life. And that may manifest itself in anger, again, drugs and alcohol, lots of different things that might not be seen as like healthy or socially acceptable, but rather than judging them and being like, what's that all about? Recognizing, okay, what's happened to them that may mean why they're manifesting and operating this way. So, just again, pain and fear trigger that fight, flight, freeze response. If a person's triggered, their thinking brain, their rational brain's not always there. It's taken a back seat. The emotional brain is really coming into play. So if they're triggered by something, they may have that pain and fear and not have the rational thought that someone else who's not experienced a trauma would be feeling. It's not to excuse any behavior, but really help explain it. So this is about childhood sexual abuse specifically, but regardless, it's really important to validate a person's experience. Don't dismiss, ignore, or silence them. Be mindful that maybe you're the first person someone is disclosing to. So you have the opportunity to listen to them, be present, and provide support. And it's okay if you don't know what to do in the moment, right? Say, hey, I'm so glad you told me. I'm sorry this was your experience. And let me see what I can do to support you. You don't have to know all the things as long as you're providing support immediately, right? So ask, listen, and offer those options. It's not possible for us to fix it. It's not our job to fix it, but we can offer options. If it comes to domestic violence patients, recognize that escaping abuse is complex, that you can't just be like, okay, well, let's figure out how you can leave tomorrow, right? But how can we be there with them? How can we help them navigate some safety and address that safety? Again, offering options is always when it comes to DV specifically too, be aware of the need to ask about abuse. Again, I talked about that screening. Sometimes maybe you're working with patients who are always with someone. They always have that one person that comes with them, or, whatever it is. Always really great to if you can get that patient alone. Maybe they disclose in front of someone that they're with, but ask if they want to talk privately about that, being mindful of that. So again, asking questions in a clear, gentle, respectful manner, be attentive, believe them. Obviously, anytime someone's disclosing something, if you're freaking out or like, oh my God, that's terrible, or really elevated responses, that's going to shut that person down pretty quickly. I'm not going to want to disclose what's going on in my life if I don't think you can handle it. So there are interventions, remind them that they're not alone, respect their cultural and religious values, right? Again, some of that may be into play on how they're reacting, what their actions are, etc. Validate their experiences, allow them to tell their story. So this isn't the time to say, oh, this happened to me too. I totally know how you feel. That's shifting the focus from them to you, right? So we want to focus on them. We want to make sure that we're listening to their story, build on their strengths. I'm really glad you told me. That must have been really, that's a lot to share. I think it's really great that you're looking into counseling. That can be a really tough step for someone, showing that looking at their wins. Responding to disclosures. So, again, you don't have to know all the things. You don't have to be armed with resources immediately. Sometimes it's just how you respond to that disclosure. Some of these examples, hey, you're not to blame. Thank you for trusting me. What happened wasn't your fault. All of those things can be really helpful. Again, providing hope through showing them their strengths, connecting with them. I think I've talked a lot about this already, so I won't keep reiterating. But again, secondary trauma is very real, so if you're someone who's heard a disclosure, that can be really hard to navigate, and maybe you don't realize how much it might affect you. So again, being mindful of your own triggers. What are your coping strategies, right? Making sure you're engaging in self-care, and acknowledging, what you are going to be able to provide support on. I hope I didn't go too fast. I know that's kind of a lot of information. I'm going to stop sharing my screen, and I would very much love to answer any questions you have. I just didn't want to, I wanted to be mindful of time.
No, that was awesome. One of the questions that we had, so what happens if you have a pediatric client that gets referred to you, or someone who calls your hotline? What services would you refer them to, or what kind of healthcare organization?
Sure. So a pediatric patient who's experienced abuse.
Mm-hmm.
Yeah. So, first of all, like I mentioned, we do see all ages, but we really we work closely with the child advocacy center. So there's children advocacy centers throughout the state of Wisconsin. We're closest to the one in Milwaukee, located out of the Sojourner Family Peace Center. Most child advocacy centers are operated through Children's Hospital, but not all of them are. But I encourage if a parent is concerned about sexual abuse, or we get them connected with a child advocacy center. When it comes to the child advocacy center, an investigation has to be in process for them to make that appointment. So whereas we are a center that anyone can walk into at any time, the Child Advocacy Center is appointment based. But what was I trying to say with that? But they have forensic interviewers on staff. And what's really important with pediatric patients, the younger especially, we want to limit the amount of times they're disclosing. So what's really great about forensic interviewers is that they're trained in asking those questions and getting more information about the abuse, and having it be taped as well, so that other investigators, things like that, can watch that. So child advocacy centers, I think, are really big, key. There's a lot of really great another Milwaukee-based organization, and again, we're Milwaukee-based, so that's going to be where my resources niche is. But there's an organization called Pathfinders that offers counseling for children who've experienced sexual abuse. So that's ages, I think they do ages 5 to 17. So we often refer to them as well. So I think those are the two big ones. Obviously, if we do have a patient under the age of 17, we do have to make a mandated report, but we will provide care. And again, we're still gonna follow what the child wants, right? We're not gonna try to do an exam if they're crying and not wanting that. We don't wanna further, traumatize that youth.
Yeah, so on that mandatory reporting aspect, so we actually, I think, for Jenna Kloss, who's here in her curriculum, they had a class about mandatory reporting, but the rest of the people here, we actually have never had a class talking about mandatory reporting. So could you just talk more about kind of like the really basics, like what is it, who is the group of people of mandatory reporting? How does that work? Like, what's the ramifications of not reporting, kind of all that stuff, because we really actually have not gone over that at all.
Sure, yeah. And I'm not an expert by any means, and I'm not a mandated reporter in my role, but essentially a mandated reporter is someone that, because of their profession or licensure, is required to make a report on any knowledge of abuse and or suspected knowledge on abuse. So if I'm, a nurse who's working with the patient and they disclose something to me about having been assaulted, in our case, if someone is being brought in for a sexual assault exam, that's that's enough to be concerned, right? So what we do is we make a mandated report, and that means it's either to Child Protective Services, or the Milwaukee, the Bureau. I'm not going to say the acronym right now, but so Child Protective Services, essentially, we'd make a report. If we think that there's immediate harm or very immediate concerns of safety, we would also make a report to the police. But it is a requirement on licensure. I don't know the specifics on what happens if you don't. I'm sure that there's some penalties in your license and in your profession. But it is something that is, and it's also firsthand knowledge. So if I'm working with someone and you hear it from someone not related or not involved, that's not going to be something you can make a mandated report on. It's that kind of firsthand knowledge that you're receiving. Yeah, yep. So definitely can be a bad thing. Also, too, there's mandated reporting as we get for older adults as well. So adults who we are concerned about, we'd call adult protective services, or APS. And there's also mandated reporting if there's concerns of abuse from a nursing home or like a residential facility for older adults.
Also for adults, they call it, in Wisconsin, it's called at-risk adults. So if
Yes.
you have like adults with developmental disabilities or even physical disabilities, even if cognitively, they can be considered at risk as well. So there's a lot of different categories and definitions and different things that you would look for. So in the adult category, there's like a financial exploitation piece that you could be reporting on. So I have a whole PowerPoint on that, and it focuses on Wisconsin's resources. But Jenna, where would you like me to put that? Do you want me to email it to you and you can disperse it, or email it to your whole cohort?
Yeah, I think you emailed it to me like in the beginning of the semester. So I think I'll send it out with this recording for people.
Okay. All right, cool.
That's kind of the plan. Yeah, that's super good. Good information to know for sure. Does anyone else have any other questions? Otherwise, I kind of have like a final question to wrap it up.
I have a question.
Yeah.
Maybe you touched on this, but do you ever work with like other hospital systems that's a lot like yours? Like I know you touched on children's having something similar in place. Do you guys ever, like, say you got a child, do you ever give them to like the children's program rather than keeping them in yours because it's more their specialty, or like vice versa at all?
Yeah, great question. So it depends on the timing. So as I mentioned, we're a 24/7 facility, right? Whereas child protective or most child advocacy centers are like business hours, Monday through Friday, and they're appointment based. So not anyone can just walk in. So what we do, and again, appointments have to be also involved with that, like a case has to be, or an investigation needs to be taking place with this concerned child abuse, or they can be referred by a healthcare provider, which is us. So if someone comes in, let's say mom or dad comes in with their child under 18 during the day, and they're really like, whoa, I'm really concerned, this is what's up. We're first just gonna see, let's call over to the CAC, Child Advocacy Center, and see if they have any openings available, and let's see if we can get them in. So we're gonna try our best to get that person over there. Sometimes we are able to get that person in. Other times they may have to wait until the next day. So then from there, we're also working, with the parent. So, this is a very stressful situation. They may be like, no, I cannot wait. We need to do this right now. If that's the case, or, maybe it's, 7 o'clock at night, right? So we can't even make that call or try to make an appointment in that moment. We will see that we'll explain, our limit, and that we don't have a forensic interviewer in place and things like this. But what we would do is, talk with the parent if they still want to be seen by us, they don't want to wait for that appointment, whatever it is. We'll do a forensic exam, but our nurses will do like a minimal fact. They might not ask all the same questions that they would ask an adult. And then we would work alongside the CAC, we'd have a medical release, we try to get information so that then things can progress with the CAC after our initial care, if that makes sense.
Yeah, that does. Thank you.
Yeah. And also, I will say too, obviously Children's has an emergency department too, and they may provide that forensic care after hours as well. Again, they won't have that forensic interviewer 24/7. But all of that, we just try to do minimal sort of fact and provide what we can, and then work for those next steps.
Does anyone else have any questions? Okay, so kind of to wrap it up, Nikki, something I wanted to talk about was, so we're occupational therapy students, so we help people with activities of daily living, and that can be anything from like simple, like getting dressed, all the way to like going back to work and like working, school, leisure, hobby activities. From your perspective and the clients that your organization serves, what are kind of the really big or the main or the really challenging or the common areas that you address with occupations, or what do you see with your clients in occupations that get disrupted because of sexual or domestic violence?
Sure. So like just what they're experiencing day to day, or like considerations that you should have when you're providing that therapy, or?
Yeah, either way, like how their daily life really gets like disrupted, kind of like for our students to kind of think about like what's OT's role, like what could we address, what's like a potential emerging practice area where like maybe we could be like, hey, like you should hire me, and I'm an occupational therapist and I think I could really help in these areas where survivors need help with their occupations.
Sure. So, I think, trauma manifests itself in a lot of different ways, and may mean that someone's experiencing pain in their body and things like that in other ways. It may just affect, sometimes folks, they can do their day to day, but then there are some days that are really great and there are some days that are awful. So healing is never linear. It's not like, oh, it's been a week, so I'm better now. It might mean that, hey, it's been a week and now I'm triggered because it's the anniversary of what's happened. Or, memories are not as filed as correctly as they are in normal day-to-day life when you're dealing with a traumatic event. So maybe I'm just remembering something. Maybe I'm triggered because I've seen something that reminds me of the assault or in any way. And I may need a minute. So I think it's really important, as you're working with folks, that especially when you're maybe helping them get back to doing things or their day to day and involving their bodies, really explaining what you're doing and why. If you're going to approach them or touch them in any way, I think it's really important to be asking that permission or explaining what's going on. I think that's probably the biggest thing that is really important to be mindful of. And just be mindful too that like folks might, be another way that folks experience trauma is by disassociating. So if they're dealing with a traumatic event, they'd be physically here, but not mentally. So even just being mindful of, are they present in the moment? How can I be sharing this information in a better way? Can I be writing stuff down? And always making sure that, you're being mindful of like that they have that control. I think those are really important pieces. And again, just knowing that there might be a disclosure and being mindful of how you can offer support in that.
Yeah, that's awesome. I think there's so many ways that OT can really, because like you said, it's pervasive and it can affect so many things and every person is so different. And that's really like how OT is awesome, is that we can help the person to what's meaningful for them and help them work on their goals. So that's super awesome.
Yeah. Also, another way people might be trauma, and I'm kind of doing this too, but like even just fidgety, they might be fidgeting, they might need to be moving around a lot, just being mindful of just how they're presenting themselves and being open and cool with all of that.
That's super awesome to keep in mind. So thank you so much for coming in tonight on a random Wednesday night. We really appreciate you bringing your expertise, because we had our documentary and we talked about it, but it's so great to hear your perspective. It's just awesome. It's so awesome. This is such a good opportunity. We really haven't had a lot of this in our coursework, so it was super informational for us. So everyone, I'll send out this recording as an email if you're interested in it, or sharing it with other students who couldn't come. And then I'll also share, Dr. Wachikrishan has a PowerPoint that she made about mandatory reporting, so I'll send that out too. But again, just a big thank you. This was so awesome. We're so grateful that you could come and talk to us.
Yeah, of course. I put my email in the chat, and then also something I didn't get to talk about, but I think is really important is ACEs, or adverse childhood experiences, which are really important with trauma-informed care. So if you've never heard of Nadine Burke-Harris or looked into her, if you just Google like Dr. Nadine Burke-Harris TED Talk ACEs, she gives a really good explanation. I think it's so important for a lot of healthcare providers and things, so really important. And so thank you for being interested and wanting to be informed. It's really important for survivors and just really great. And April is Sexual Assault Awareness Month, so this was a really great segue for you guys in this. And don't hesitate to reach out if you have any other questions about anything. So yeah.
That's awesome. I'll put that TED Talk in the email too. Otherwise, if no one has,
so good. If you want to, I'll send you the link if you want to share it. So
awesome sauce. We love a good tech talk. Yeah, we had a mental health class. The curriculum is also like changing over, so it's kind of weird because like some people have had some classes and some people haven't. But we had a mental health class and we talked about the ACEs, so we're like a little bit informed about that, but not like a ton. We just had like so much material that we probably talked about it for like 10 minutes at one time. So
sure,
definitely like to know more about that. But otherwise,
yeah, and I could talk forever about
put
it in the chat. So there you go.
But perfect. Awesome sauce.
Yeah. Okay.
Otherwise, if no one has any other questions, thank you so much everyone for coming, and we'll see you later.
Bye.
Goodbye. Thank you for coming. I think I can just end this meeting and then it will get the recording.